looking at patients who have lid disease, again, it's all chronic. It's been there for decades, in my belief, and we usually don't see them early. And looking at Lou Groden, he talked about this back in 1991, published in the journal Cornea, that patients who have chronic lid disease have excessive microbial bioburdens, meaning the bacteria that are on their lid. And because of these bacteria, there are inflammatory toxins that are produced by the bacteria, and then the body secretes cytokines to kill the bacteria and just in this inflammatory response. Bacteria also give off lipase, which saponifies the oil, which is toxic to the ocular surface, and a biofilm can form, which can be toxic to the surface and make it unhealthy. The role of pure hypochlorous acid has been studied for years, and I'll show you the reference shortly. But when hypochlorous acid is actually something that is found in neutrophils, if you remember the neutrophil burst that we all learned about in medical school, and how neutrophils kill bacteria. And when these neutrophils give off hypochlorous acid, it kills the bacteria. And it not only kills bacteria, it neutralizes the inflammatory toxins on the surface that have been released. It also helps to nullify the cytokines, and also prevents biofilm formation. Avenova is one of several products in the market, but the only one that's 100% pure hypochlorous acid. And this does similar things that we've seen in vivo, but also in the laboratory. And it also decreases bacterial overpopulation. It inactivates inflammatory bacterial toxins, degrades bacterial enzymes, including lipases, and also prevents biofilm formation. So it kind of seemed like a normal step to be used in an area where we have similar findings. And those products on the market are listed up on this slide. Avenova, which is 99% pure hypochlorous acid, Ocusoft hypochlorous, 73% hypochlorous acid, and has 27% sodium hypochlorite, also the active ingredient in Clorox. Microcin also is a similar product, but has 59% hypochlorite. And so we have used all of them and have chosen Neutrox with Avenova because it's worked for us. So this slide, now we have all these high-tech slides, and here you see this low-tech slide. But it's interesting because this was published in the Proceedings of the National Academy of Science back in 1981. So this is what we had back then with little Mac machines. And so this is from the journal that showed how hypochlorous acid can work in the body or on toxins. So what this is demonstrating is the bacteria releases toxins. That's the little green thing over here. And this little square thing is representative of the human cell. And the toxins are destroying the extracellular matrix. The human cell then responds with its own pro-inflammatory cytokines. And the nice thing about the Neutrox with hypochlorous acid, it can inactivate the inflammatory bacterial toxins. It can decrease the pro-inflammatory cytokines and also kill the bacteria. And that's from the journal article. When looking at the efficacy of Avenova in vitro and having a plated group of growth of organisms, and then applying the Avenova product onto this plate for 67 seconds, what can be seen is there's a gross reduction, a markedly reduced reduction of bacteria. And I know this slide's tough to read, but I'll point out. So it was tested against a multitude of organisms, including gram-positives, gram-negatives, and fungi. And the gram-positive organisms were Staphylococcus, Staph methicillin-resistant aureus, Staph epidermidis, Bacillus, Propionibacterium acnes, and Strep. And all of these bacteria had a reduction of greater than 99%, or 4 to 5 log unit reduction. Looking at gram-negative bacteria that we see in the ocular surface, Klebsiella, Moraxella, Pseudomonas, also the same 99% reduction in vitro. And also with fungi, Candida and Aspergillus. So it kind of mimicked very well in vitro what we saw in vivo. And at ARVO last year, Doctors Branch, Patel, Breimer, and Epstein presented their study looking at the bacterial load on the skin on humans before and 20 minutes after the application of Avenova, and this was the skin that was cultured just below the lower lid. And patients had to have lid inflammation that would be treated if you would move on, so they had to have disease. Specimens were collected before and 20 minutes after application of Avenova. There were 36 subjects, and female 22, male 14, and looking at the data. And hopefully this slide prints out nicely, but looking at the reduction of the bioload of bacteria at 20 minutes, Staphylococcus represented 60% of the isolates, which is pretty representative of what we see now. And of all the Staphylococci, 99% were reduced, and the Staph epidermidis, which is seen to be the one bacteria that are very involved with endophthalmitis, also 99+% were reduced, not dissimilar from what was found in vitro. Interestingly enough, looking at the most common bacteria, which is Staphylococcus, Propionibacterium, acnes, again, what we see in worried about endophthalmitis, Corynebacterium, and other species, before and after the treatment with Avenova, with the reduction of bacteria, they still kept the same diversity. So at least short term did not see a kind of one group of organisms that was kind of more resistant than others, which is very helpful. And so the group felt that with this test that they did, that the Staphylococcus were 60% of the total isolates, Staph epidermidis were 36% of the total isolates, and P. acnes 22%, what we worry about, and that they were able to show that it was able to decrease the bacterial load. As you know, those of us who operate, we all use betadine for our pre-treatment. Leave it on for 2 minutes, and it kills bacteria by oxidation. But Avenova has been compared to betadine in its killing efficacy. It's actually less toxic than betadine to the ocular surface. If you ever left betadine on the surface too long, it can beat up the ocular surface pretty well. The cornea doesn't like it. And in this group is done by the study was done by University of Pittsburgh. D.P. Dhaliwal did this. And they looked at the spectrum of bacteria that were sensitive to betadine and as well as Avenova. And the Avenova onset of activity was twice as fast, and many strains that were not killed by betadine, such as Serratia marcescens, were killed by the Avenova. And so one thing that we've taken away, and we would not want to treat meibomian gland dysfunction with an antibiotic to kill the bacteria. So you wouldn't want to use fluoroquinolones or aminoglycosides, because why would you use an antibiotic when you would worry about resistance? We did talk earlier about using azithromycin, and just so you know, when we use azithromycin, it's not for the bacterial killing effect, it's for the anti-inflammatory effect. That's why we use these medications. But typically, if you could kill bacteria with a more gentle and more effective source of using Avenova, would be much better, and you'd not have to worry about getting resistant organisms. Likewise, Avenova was evaluated in bacterial lipase activity, and Art Epstein presented his data at ARVO in 2015. And what this group looked at is the lipase activity versus all of the topical application lid products that were on the market, prescription and not. Clearadex, Avenova, baby shampoo, which many people used, Ocusoft Lid Scrub and the Lid Scrub Plus, TheraTears Sterile Lid, and also sterile water and the control of background. And the only product that had like no lipase activity, which is similar to background, no lipase activity, was the Avenova. Everyone else increased in time, even in the presence of those. So the Avenova is the data was very, important to us.
So in terms of lid therapy, so our goal behind these patients are not only debriding the lid, but we want to try to change the melting point and the health and the quality of their oils in the eyelid margin. So as Dr. Berdy mentioned, we're not treating them with antibiotics because we're trying to kill bacteria per se. We want to try to affect those lipases and change those oils so the patients are now producing better oils after we've either debrided them, probed them, done LipiFlow. And so using this lid therapy or lid hygiene therapy we want to try to get those oils flowing and more normal and melting at body temperature. So using a product like Avenova that we know inactivates those lipases that are produced by bacteria, reducing the bacterial load that actually feed on those abnormal lipids, block any inflammation, any cytokines that are on the lid margin and actually migrate into the ocular surface tear film, blocking all the inflammatory mediators that are occurring on the lid and getting into the tear film, and basically removing any barriers in that biofilm. That's where this is the toothpaste or the flossing to kind of help maintain the opening of the oil glands. And it works concomitantly with lid therapy, so I think debriding the lid with warm compresses and doing lid hygiene and using a product like Avenova. If you use steroids and antibiotics like we've had in the past, that has limited efficacy on the oil glands. It actually kills the bacteria, but it doesn't have that same effect on liquefying those lipids. But using it in the acute phase when there's a lot of inflammation, obviously using steroids is helpful. But using Avenova as an adjunct and using it long term is safe, but also effective. And I think that if you've had experience using the topical pharmaceuticals like Xiidra or Restasis, if patients have lid disease, over time, off-label, patients' lid disease improves also as their ocular surface improves. But I think using something that addresses the eyelid, something such as Avenova, works very synergistically with pharmaceuticals like Xiidra and Restasis. So the onset of action of the topical agents, especially if patients have more lid disease than they do ocular surface disease, things like Xiidra and Restasis take anywhere from 2 weeks is what Shire says with Xiidra, and Restasis may take 6 weeks to 3 months. Using something concomitant to treat the lid disease like Avenova can make that onset of action of treating the ocular surface much quicker. And the analogy I give to patients is when we measure their tear osmolarity and look at their tears, you could see all the debris in their tears. So osmolarity is measuring the debris on the ocular surface. So I give them, we live in St. Louis, so we have the Mississippi River there, so I say, your river is polluted. And what we want to do is we want to try to clean up the river and clean out all that debris and the pollutants in the river. But if the river is polluted and we're in a drought, all the pollutants that are in the river end up on the riverbanks. And the banks of our ocular river is our eyelid. And all that debris ends up on the eyelid, so using something to clean up all the trash on the eyelid will actually help keep the river clean. And that's what we want to do, is we want to keep the river clean so we could, so patients could see better and not have symptoms of dry eye. Using things like tea tree oil, which has been shown to kill Demodex. If any of you used that before, we know that's very toxic to the ocular surface. Patients, it burns and it creates almost more inflammation, and that's the last thing we want to do. But even though it does do well in terms of killing Demodex, Avenova is much better tolerated. And of course, manual lid expression works great, but that's just unclogging the oil glands at that time. Using something is to chronically treat the patient and keep the oil glands from clogging up again is important, and that's where Avenova has a great role in your practice. And so looking at some examples of before and after pictures, this top picture looks more like anterior blepharitis with all the collarettes, and you can see how I don't want to make the claim that just putting Avenova on there, it's just going to eat it away. There is definitely some hygiene associated with it. Here's again some anterior blepharitis where there's all this scurf of the lashes and after 2 weeks of therapy. And again, there's before and after pictures of using this. Even within 2 weeks, patients have a very quick response to therapy. The also nice thing is there's no age restriction, so we sometimes have children that come in that have chronic styes and chronic lid disease, and this has been well tolerated for parents to apply this to children. It doesn't sting. There's no really time restrictions. Patients could use this chronically over years and not have any cytotoxic effects, such as patients using steroids. You don't want a patient to be using a steroid topically because it could thin the skin. So this doesn't have any of the side effects or any negative side effect profiles for using it chronically.